The topic of my talk is the challenge or the pediatric challenge in percutaneous treatment of coronary obstructions after Kawasaki disease. And I think the baseline of the challenge is already that we do not have a very clear understanding of the etiopathogenesis so far. We do have limited experience. Do we have the appropriate material, at least for small children's? And kind of based on the limited experience, there is not a good evidence-based recommendations. Coming back to etiopathogenesis, and I think all KD interested physicians know this really good publication, giving an idea of what is going on the coronary artery level. But this experience is based on 41 cases only. I think all adult cardiologists would say, do you really know what's happening there? Um, Most of them were autopsies, 8 after transplant. Interesting is, why did they die or needed a heart transplantation? Most of them were due to thrombotic coronary occlusions. In the acute phase, there were some coronary ruptures, and there were 6 occlusions without evidence of thrombosis. I mean, this publication is really nice. Not, I don't want to diminish these results, but having in mind that the only histological real good workup is based on 41 cases, I think we have to be honest to ourselves. There's probably much more we should know on this level. Talking about experience, and some years ago, being an interventional cardiologist, being interested in Kawasaki disease, I started a registry where all conventional coronary angiographies are collected. I started it not to push coronary angiography, but to get an image. So what is done on the real world? It started in Germany and it spreads out over Europe, and hopefully more countries will participate, or we may unite several registries. So far, we have collected around about 200 patients, in which 280 conventional angiographies have been performed. And in only 19 of these 280 cath procedures, an intervention was necessary in 12 patients, meaning so some needed at least 2 interventions. So this is fairly, luckily said, it's very a small number. Most of them needed plain old balloon angiography. There were only 2 stent placements, local lysis, and some kind of recanalization. We will talk about these options also later. The most coronary artery which had been addressed was the right one. So now it shows some experience, some own experiences, and gives some possible interventional possibilities to your hand. So this is the first one is a 8-month-old girl. Actually, her mother was Japanese, the father German. So she happened to have had severe therapy, refractory KD at the age of 3 months. We were only able to control it besides corticosteroids, immune globulins, of course, with high-dose anakinra, and I think the game changer was in infliximab. At the age of 8 months, I mean, of course, she was in regularly follow-up. At the age of 8 months, she presented with in a routine follow-up, and we do routine laboratory values, and there was just some mild elevated TROP-T, which we indicated to do a closer look to the coronaries. So here you see the selective right coronary angiography, and here in this red circle you see a relevant severe stenosis, um, which we treated. And there we come to one of the challenges in treating very small children with simple balloon angioplasty. So this was a 6 kilo baby, so we didn't want to have a 6 French sheath inside the coronary. So we just let a small 4 French sheath, um, putting the balloon inside the coronary, and so we have to have some other landmarks to know where we have to do the intervention, because we can't do angiography while we do the intervention. However, I think we were in the right position, and as you can see, the contrast flow through the stenotic area improved. No? When you look at the stenotic, especially pre-aneurysmatic area, you should not only be aware of the vessel before, but also take care of the flow. So you better get an impression how the stenotic lesion is like, and you also should look how long does the contrast take to get out of the aneurysm. So this was 1 year later. I think the proximal part of the aneurysm, it still looked nice, but in the distal part there was some lesion, and we were confident we would improve it by treating, so we did. And at the right side, this is now 3 years after acute phase of KD. Um, there is no stenotic lesion anymore. Of course, there is some intimal and medial hyperplasia in this region, which we saw in OCT. But I think by now we don't need, hopefully for a longer time, conventional angiographies. The next case slightly different. It's a 9-year-old boy who was not known to have KD, and he presented to our service with signs of acute myocardial infarction, at least from the ECG TROP-T. So in echocardiography, there was already the suspicion, and we confirmed it by conventional angiography. There were an aneurysm here of the LAD and a complete occlusion of the RCA, which we carefully did wire crossing combined with aspiration and local lysis to reopen this vessel. We had the impression to do good with some ballooning here as well, and this is the final result. I think we reopened it nice. We did not have the need of another angiography. This is like 2 years ago, and on exercise testing, there are no signs of hypoperfusion. The last case, at least from my own experience and those who have been in Montreal, they presented this case already. It's a 9-month-old boy, also without a known history of Kawasaki disease. And he did not only present with the signs of acute myocardial infarction, but also with cardiogenic shock. And again, in a quick echo, there was already made a suspicion, so he quickly went to the cath lab, and besides seeing Here, proximal right coronary aneurysm, a distal aneurysm. There was a complete obstruction of the left coronary artery, which again, luckily we were able to cross by wire. We did some ballooning starting distally, going proximally. So we reopened it, nevertheless left some injury here, so we stented it. But I mean, you may realize that this left heart is really severely affected. So also we reopened it. This did not recover. So he ended in left ventricular assist device and ultimately in heart transplantation. What other options do we as an interventionalist have available to maybe help the one or other child, and why are these options really good for children? Just to present what other options we do have, there is the road ablation. There are different tools available. I think the most commonly used, well, at least in our service, we use is the one from Boston Scientific. You have different sizes of burrs, which are diamond covered here. It starts from 1.25 millimeter and going up to 2.5, and it goes through a 6 or 8 French guiding catheter, respectively. I haven't used it in children with Kawasaki disease, neither in adults, so my experience here is limited. Experience available is from Japan. There are also some older studies which indicated at least good short-time results. This publication from 2022, they also looked for long-time results. This case series included 14 patients, with 3 of them being children. And due to the coronary artery size, of course, smaller burrs are used, and the lumen left after the treatment is an indicator for reclosure. Well, depending what you do afterwards with the vessel as well. At least the 3 children having been treated by rotational ablation, all of them after 1 year were occluded. Cutting balloon, also an option for severely hardened calcified stenosis. Cutting balloon is nothing new. It had been used before the stent area which started in 1993. It comes with a diameter from 2 to 4 millimeter, different length, and the blade itself is about 0.1 millimeters. We as pediatric cardiologists, we do not use it really frequently in coronaries. I have never used it in Kawasaki disease, but we use it in other kind of vascular lesion, especially after surgical treatment, or in renal artery stenosis. I think that's a good option. In Kawasaki disease, there is one child having been treated also with cutting balloons, which is from France. This 13-year-old boy, having had KD or refractory KD at the age of 4. He had a chronic total occlusion with collateralization. At least in the image, doesn't look that bad. However, they indicated antral perfusion and to reopen it. So they used road ablation before they were able to come through the lesion with a cutting balloon, and finally using high pressure balloon in this area. They performed OCT afterwards, and besides seeing the circumferential calcification, there were also an intimal flap dissection here. So they stented this area. However, there was one part where the stent did not fully expand. So again, using high pressure balloon, And I think antigraft perfusion is nice. However, there's some extravasation. In the 1 year follow-up, they saw two new aneurysms, which were pseudo-aneurysms or false aneurysms. And that's something in general, not only after the use of stents or cutting balloons, something you have in mind. That's nothing what you normally see that frequently in older adult patient with coronary artery disease, but there are quite some reports in Kawasaki disease. So these areas were excluded now with two covered stands, and 6 months later still looked nice. However, with some new intimal proliferation in this area. The last tool I want to present is the intravascular lithotripsy, something which comes from the nephrologist. So by ultrasound fracturing kidney stones. So this balloon is emitting ultrasound intravascularly and thereby fracturing calcified stenotic lesions. It comes from with a diameter from 2.45 to 4 millimeters. Needs a 6 French guiding catheter. I haven't used it in KD either, to be honest, but I think it works nice. I've used it once in another situation. It was a 7-year-old boy. Due to very small bowel syndrome, he was dependent on TPN and had a Hickman catheter. All vessels were occluded in this patient, so he had chronic thrombosis there, leading to thrombotic pulmonary occlusion. Here, operation was not indicated yet in this severely ill patient, so we tried to open some vessels by cath measures. Cutting balloon, high pressure balloon was not successful, but ultimately with intravascular lithotripsy, perfusion was better. Um, this child was operated some weeks later, and at least due to the surgeon, they told me, well, that the vessels I treated with intravascular lithotripsy, this calcified thrombus was much more easier to take out. So that's what I know. There's one case I found published who was KD case who was treated with intravascular lithotripsy as well, not a child. Um, he's an Hispanic male treated in the US. At the age of 7, he already happened to have had calcified stenosis. PCI was unsuccessful, so he went bypass operation. 10 years later, the bypass was occluded, and probably due to a relevant severe proximal RCA stenosis, reopening by rotational atherectomy, high pressure ballooning, cutting balloon, and also chocolate balloon. Chocolate balloon is a semi-compliant balloon which is in basket by a nitinol frame, so therefore putting more controlled forces and non-forces towards the artery. So you want some small dissection, but not to go over the whole artery vessel. Um, I think it didn't look that bad. However, they were not convinced yet, so they went for a lithotripsy, and they also realized a little extravasation. So they put a drug-eluting balloon followed by two covered stent. A follow-up is not published yet. So I'm coming to an end. I think I can conclude PCI for coronary artery obstruction in children is really challenging. Um, at least in low incidence country, you should be aware that some children might not have been diagnosed with KD during the acute phase, so they may present with acute coronary obstruction, at least in my center, those with complete obstruction were those who were not known to have had KD. The others with respective anticoagulatory treatment, we haven't seen any complete obstruction yet. The equipment is probably not the best or not made for children, at least. However, if there is an urgent need of intervention, you should do it. And if you need specific help, talk to your adult cardiologist. And last but not least, I think it should not always be me or my country first. It should be a collaboration of everybody. We are all working together. We should all work together for the same problem. And I think every interventional cardiologist, at least I'm really happy if there's a problem and I can help. I'm happy to help. I think you should contact those who have maybe some more experience. We don't have much experience, but maybe we have had in a similar case. So thank you.